Welcome back to Ophthalmology for undergraduates and postgraduate beginners. Today, in the clinical cases kept for examinations for undergraduate students, we are going to discuss about aphakia. All of us know anatomically the normal crystalline lens is located behind the iris on the anterior face of the vitreous, which is called as the patellar fossa. This is normal. Aphakia is absence of crystalline lens from the eye. So in this picture, there is no lens being the eye or behind the iris. So this is called as aphakia. There is another situation where the lens is present inside the eye, but it is not located in the patellar fossa. This is also called as aphakia because this is going to optically affect the eye, leading to change in the refractive power of the eye and decreased vision in the patient's eye. Now let us try to learn what are the causes for aphakia. The first cause is a congenital non-development of the lens. There is no development of the lens in the child due to various factors. Second thing is post-operative. We have done a cataract surgery for a patient. We have removed the cataractous lens, but due to certain reasons, we have not implanted the artificial intraocular lens into the eye. So the eye becomes aphakic. The third cause is trauma. An injury to the eye. It may be a blunt trauma or a trauma which breaks the eyeball. It causes ruptured globe of the eyeball. In blunt trauma, what will happen? The lens which is supported by the zonules may rupture all around and the lens may fall into the vitreous or it may come into the anterior chamber, making the eye aphakic. In penetrating trauma or ruptured globe, the lens may be thrown out of the eye, making the eye aphakic. The next cause is perforated corneal ulcers. A patient developing a corneal ulcer, if the ulcer is not brought under control at the earliest, the cornea may become penetrated or perforated. The hole may develop in the cornea. So when the hole suddenly develops in the cornea, the pressure inside the eye will throw out the contents of the eyeball outside, including the lens, leading to aphakia. Couching. In the ancient times, the treatment for cataract is couching. What is this couching? Those days there were no surgeries. They know that the lens has become cataractous and it is obstructing the light rays passing into the eye. So what they did that time is they just artificially make a blunt trauma on the eye so that the lens is dislocated into the vitreous. Thereafter, patient gets back some vision. So that is called as the couching technique. We have certain other causes for aphakia. One is a hypermature cataract. When a patient is having a hypermature cataract, the vision will be very much reduced. As the lens has become degenerated and become so much cataractous, the zonules also will be very much degenerated, and sometimes because of their weakness, the zonules may spontaneously break and the lens may fall into the vitreous. The next cause is pseudo-exfoliation syndrome. Pseudo-exfoliation syndrome is one more degenerative condition where there will be dandruff-like material formation. This dandruff-like material formation can weaken the zonules of the lens, leading to the spontaneous breakdown and dislocation of the lens into the vitreous, causing aphakia. An aphakic patient usually approaches an ophthalmologist for the following problems or symptoms. The first symptom will be severely reduced vision. They can hardly see anything at a distance more than 1 meter. Some patients who are previously myopic, they have a myopic refractory error, can see little bit better than a emmetropic patient. Next symptom for which the patient approaches the doctor will be, there will be loss of accommodation. We have already learned what is accommodation. The lens can change its shape to make the eyes see both at a distance as well as a near. But here, because of the absence of lens, this shift in the focus is not possible for an aphakic eye. The next symptom will be color vision. There will be some defect. We know that a normal crystalline lens can stop most of the ultraviolet rays coming from the external atmosphere. Here, because of the absence of lens, the ultraviolet rays go into the eye and they fall on the retina directly. Most of this time, the patients say that whatever they see, they appear blue in color. Now, let us learn the signs of aphakia. When you check the visual acuity of a patient with aphakia, it will be usually less than 1/60. If a patient is emmetropic or if the patient is hypermetropic previously, then this aphakia will reduce the vision so much. If the patient is a known myopic patient, the vision may be little bit better even in aphakia. Most common cause for aphakia is postoperative. In a postoperative aphakia, you should definitely look for a scar in the eye. It may be a scar in the sclera, in the superior sclera, when you have done a small incision cataract surgery. It may be a scar in the limbus with suture marks in conventional cataract surgeries. It may be a scar in the cornea itself in phacoemulsification. Sometimes you can see scars in abnormal locations when the aphakia is due to trauma, that too a perforating or penetrating trauma of the eye. Next sign we should look for is the depth of the anterior chamber. The depth of the anterior chamber will be deep in aphakia. Now we can see these two pictures. The first picture, the lens is in its position. The second picture, the lens is not there. What this lens does in a normal eye is, it just supports the iris on its surface. So what will happen? The anterior chamber will be of a normal depth, which is 2.5 millimeters in the center. When there is absence of lens in the patellar fossa, the iris loses its support of the lens, so it is freely allowed to fall backwards. So the anterior chamber depth becomes a larger one. We can see in the eclipse sign. This is a normal picture. When you put light from the temporal side, you can see a small crescentic shadow on the nasal iris. This is normal. When the iris falls back like this, you will not see any shadow at all in the iris. So this proves that the anterior chamber is deep in aphakia. Another important sign in aphakia is iridodonosis. Iridodonosis is tremulousness of the iris. The iris vibrates inside the eye with the movement of the eye. You can see in this video on the side what this iris is doing. This is because the iris has lost the support of the lens. It is between the vitreous humor and the aqueous humor. Both are liquid media. So the iris is floating in these two medias, and because of the movement of the eye, it is fluttering or tremulating inside the eye with the movement of the eye. The next important sign you should look for in a case of aphakia is peripheral iridectomy. Whenever you do a surgery in a patient for cataract, you are not able to implant an artificial lens into the eye, that is an intraocular lens. We always do a peripheral iridectomy. We always make a small hole in the 1 o'clock position in the iris in its periphery. Why we do this? We do this because when there is an aphakia, what will happen is the vitreous, which is separated from the pupil by the normal lens, now freely moves forwards and comes and obstructs the pupil. It will just block the pupil. You know that the aqueous humor is secreted by the ciliary body and it comes into the anterior chamber through the pupil. When the vitreous humor blocks the pupil, what will happen? The aqueous humor gets stagnated behind the iris, leading to increased intraocular pressure, and that may damage the optic nerve and that may lead to a glaucoma. Next sign in aphakia is Purkinje images. What is this Purkinje images? You throw light on the patient's eye, you can see the reflections of the light from 4 surfaces. The anterior surface of the cornea, the posterior surface of the cornea, anterior surface of the lens and posterior surface of the lens. 4 reflections of the light will be seen. But in aphakia, because of the absence of this lens, the 3rd and 4th reflections will be absent in the eye. You can confirm aphakia by 2 more signs. One is the patient will be highly hypermetropic because of the absence of lens. When you put a +10 dioptric spherical lens in front of the patient's eye and you check the patient's visual acuity, there will be an enormous increase in the visual acuity of the patient. That will confirm aphakia. Because of this hypermetropic shift in the eye due to absence of aphakia, when you look and see the retina of the eye, the optic disc will appear smaller in size as you see in a hypermetropic refractory errors. We have already told in Purkinje images, when we throw light on the patient's eye or person's eye, there will be a reflection from the anterior and posterior surface of the lens. But in aphakia, because the lens is absent, there will not be any reflections and the pupil or the pupillary area will appear black in color, that too a jet black in color. What is this jet black color? We have all seen a newly painted blackboard in schools. It will be so dense and dark. That kind of a color you will see in aphakia. Now let us see how to correct a aphakic patient. How to improve the visual acuity in aphakic patient. One is giving spectacles to the patient. You can give spectacles of high plus power, so that the patient can see the distance better. The second thing is using of contact lenses. Contact lenses can be worn over the cornea so that the vision may improve. The third and most commonly followed treatment for aphakia is secondary IOL implantation. What is the secondary IOL implantation? After the patient becoming aphakic, we do one more surgery to keep the intraocular lens inside the eye. You know that in aphakia, the capsular bag is not present. Because the capsular bag is not present, You cannot just like that put the IOL inside the eye. If you put the IOL inside the eye, it will fall into the vitreous. We want to position the IOL exactly behind the iris. Then only patient will have improvement in vision. But because of the absence of the capsular bag in the eye, what we do is we suture the IOL to the sclera, or we stick the IOL with the glue to the sclera. So that is called as scleral fixated IOLs. Another method is iris claw lens. What we do is a special type of intraocular lens which can be positioned in the center of the pupil by attaching the haptics to the iris. So it holds the iris and it stays in its position and improves the vision of the patient. Now I have drawn two pictures here. One is the scleral fixated IOLs. What I have done is I have drawn an IOL here which is attached to the sclera by sutures. The second one is iris claw lens. The lens is kept in the pupillary area and the lens holds with a claw to the iris. So it remains in its position to improve the vision. The common question asked in the examination: what is the disadvantages of wearing aphakic spectacles? If you are going to give a spectacle correction for aphakia, the first problem the patient will face is the patient will be wearing a very thick and heavy spectacles that will cause discomfort to the patient. Such thick spectacles. If you wear such thick spectacles, that will affect the patient cosmetically. The patient's eyes and face looks ugly. Everybody looks at him as if an alien is in their group. Third problem an aphakic patient faces is he will have a diplopia. Suppose the one eye is normal, other eye is aphakia, where he is wearing a thick spectacles. What will happen is the image in the aphakic eye because of the spectacles will increase by 30%. The normal eye will see the image like this. The aphakic eye using the spectacles will see a bigger image. So there will be diplopia, one big image and one small image. If both the eyes are aphakic, what will happen? Both the eyes with aphakic spectacles, the images will appear 30% bigger, and whatever thing the patient sees, they will see as if they are very big ones. Another important problem an aphakic patient wearing a spectacles has is poor hand-eye coordination. The patient can see only those things which are falling in the center of the spectacles clearly. Those things on the periphery will not be clear, so he will find it very difficult to do his work, because if he is not getting practice to the spectacles, there will be a poor hand-eye coordination. He wants to do something but the fingers or hands will not go there. The vision will be somewhere else. So that kind of difficulty a patient will have. Spherical aberrations is one of the biggest problems in aphakic patients wearing a spectacle because of the thick center and thin periphery in aphakic spectacle lenses. That will lead to a parabolic effect. The normal image like this will be seen like this. Next problem will be roving ring scotoma or jacking the box phenomenon. Whatever the patient sees through the optical center of the lens, the center portion of the lens will be clear. Those things on the periphery will not be very clear for a patient. Suppose a patient is wearing aphakic spectacles and without moving his head, he turns his eyes this way and that way. What will happen is the image in front of him will be suddenly seen and and suddenly it will not be seen. It appears and disappears due to spherical aberration that is called as jack-in-the-box phenomenon or roaring ring scotoma. Another important problem is chromatic aberration. The spectacle lens is thick in the center, thin in the periphery. So it is like a base in prisms arranged in a circular fashion. The prisms are very big because of the thick lens. So it will cause high prismatic effect and that will lead to chromatic aberrations. The patients will be seeing several colors, just like having a colored halos. One more thing we should know is disadvantages of using a contact lens in aphakic patients. This is a normal image. This is the image seen by a patient using contact lens. This is the image seen by a patient using spectacles. You can see that the size of the image increases. There will be 8% increase in the size of the image in a patient using contact lens. There will be a 30% increase in the size of the image in a patient using a spectacles. Most of the problems that is seen by a patient using spectacles will be very much reduced in patients using contact lenses. Finally, I want to tell one thing. An aphakic patient, if you do a secondary IOL implantation in him, definitely the patient's vision will improve a lot and the patients will be happy. With this, we'll stop here. We'll see some other topic in the next session.